Why are female lifters peeing on the platform? That is the question that we are going to try to answer today. Hello, everyone. My name is Dr. Christina Previtt. I'm a pelvic PT and PhD, where my postdoc research is looking at heavy lifting in the pelvic floor through the lens of pregnancy and postpartum. As a previously competitive Olympic lifter and power lifter who did CrossFit for many years, the world of heavy lifting is one that I know very well. In the last 18 months, we have actually seen a huge increase in our number of studies that are evaluating what is going on at the pelvic floor to try and give us a little bit more clarity about this question. And so I'm excited to dive into this conversation with you. First, what we know is that there is something in our female athlete population that is increasing their risk for pelvic floor dysfunction compared to general population age-matched controls. We know that anywhere between 30 and 50% of our lifting athletes, irrespective of their level of competition, are peeing, and most often in their heaviest movements. So squat and deadlift being the most common, deadlift reigning supreme being number one. In our Olympic weightlifting movements, it's the clean, where you go from the ground to the shoulder in one movement with speed. When we compare this to our other female athletes, this kind of comes in the middle of the pack, right? Where our really high impact athletes, female athletes like our gymnasts and trampoline athletes, can have a rate of pelvic floor dysfunction as high as 80%. And some of our low impact athletes that are not doing a lot of pounding, whether that's running, kind of pounding, cyclical pounding, or lifting weights, are lower. And some rates are, 5%. We have a systematic review that just got published that shows that consistently we're seeing this between 35, 30, and 50% incidence of pelvic floor dysfunction. Most commonly, this is peeing when you don't want to be peeing, fecal incontinence, usually gas. So they're farting in the bottom of their squat, or they're feeling vaginal heaviness. But leaking, stool, gas, or urine is by far the most common symptom. When we are looking at factors associated with those that are lifting, the conversation gets a little bit messy. There was a new study that just got published that showed no difference if they had a vaginal birth versus not, if they had used a weightlifting belt, etc. But that isn't consistently shown in the literature. And this paper was actually understudied, or underpowered rather, to make those types of comparisons with the number of people they had in their studies. What we see clinically, and what some of our earlier research is starting to show, is that getting and approaching your 1 rep max, fatigue, bracing inappropriately or losing position, how you are using your weightlifting belt, are all kind of risk factors that are specific to the sport itself. And this is part of Lolita Weekender's, I'm going to post the references below, some of her cross-sectional work that is looking in powerlifting and weightlifting athletes. These are all kind of factors associated with the movement that are influencing if, how much, or how often an athlete is leaking. Then we have kind of factors that are outside of the lift itself, right? Where we know that your pelvic floor is not just working in isolation. The best example that I give to many of my clients is they take a week off from the gym, and it's because they were sick the week before. So they were feeling really trashy. They didn't come into the gym. They come in the first day and their pelvic floor feels worse, or their symptoms feel like they haven't improved at all. And they were thinking, what the heck is going on? Because rest should make this better. But they were vomiting and coughing the entire week. So yes, your quads have not had a workout in the last week, but your pelvic floor absolutely has. And so factors like an aggressive cough, constipation, sexual activity are all things that are going to influence that pelvic environment. And then things like pre-workout, caffeine, alcohol, nutritional considerations are also kind of this other bucket of symptoms that may be influencing how often people have symptoms. Then when we look at pregnancy and postpartum, there's this discussion around heavy lifting and its influence on the pelvic floor. And this is by the load lifted itself, and then also the breath strategy that we're leveraging with bracing. When you lift over 80%, what's important in this discussion is one, a proper brace has a coordinated co-contraction of all sides of the core canister. So abdominal wall, including TA and our obliques, our chest wall diaphragm, lumbar erectors, and multifidi, and then our pelvic floor. When we are bracing, that co-contraction occurs automatically. So our body responds to the load that we are applying on it and activates in kind. So if you're lifting 50%, your brace is going to activate at 50%. And you can put that under control, like your own volitional control around how you're bracing. But then also your body does it automatically. For example, if you're going to lift a couch in your house. When we go over 80%, we stop inhaling and exhaling on a coordinated rhythm. This is called the Valsalva. And there's a lot of discussion around the Valsalva. It is way too much to dive into the Valsalva in this video. But important thing for us to know is that the brace occurs independent of the breath. And then the breath can be added in to increase stiffness across our midline so that we can exert more force. And so when we go over 80%, our effort is high and our breath shuts off. And so we stop breathing, which is the Valsalva brace maneuver. In pregnancy, there is this belief that your pelvic floor is already under so much strain because of your weight of pregnancy and the fact that your pelvis is widening. So your static supports, your ligaments are loosening in order to prepare for delivery. So your dynamic supports, like your glutes and your pelvic floor, are under more load. And so maybe our body shouldn't be strained or stressed to the max when looking at lifting in pregnancy. And that was the hypothesis. Honestly, that was my hypothesis. That's what I thought in 2020. And then my own data has kind of proved me wrong, where in my cross-sectional study that was published in 2023, we didn't see any difference in rates of pelvic floor dysfunction for those postpartum who stopped the Valsalva maneuver and that hard bracing strategy versus those that didn't. And my retrospective study, which is currently under peer review, corroborated those findings, and it was the same thing. So in the pregnant period, our new data is supporting the use of the Valsalva maneuver. Bracing is going to be needed and necessary if you are lifting in pregnancy, and then we're kind of going into the postpartum period. When we are thinking postpartum, one of the things that is going to influence how women feel within their own bodies is what happens during labor and delivery. So the way the baby came into the world. So did they do a trial of labor before an emergency C-section versus a planned C-section versus a vaginal delivery? In that vaginal delivery, was there any tearing? Is this your first pregnancy versus subsequent pregnancies? Was there a forceps vacuum delivery? Was there episiotomy? Like a lot of the questions around what happened during your delivery are going to influence how you feel within your pelvis and pelvic floor postpartum. And then additionally, the size of your baby and the size of baby's head are going to influence the potential risk for pelvic floor issues, levator, ani avulsions, etc. Then that has this whole secondary conversation around lifting in the postpartum period. And so what we know from vaginal delivery is that there is an increase in vaginal wall range of motion that is expected after a vaginal delivery. The opening of your vagina is going to increase and your bladder neck drops during your pregnancy that may persist into that postpartum period. And then add lifting on top, which is going to increase pressure through your belly. The question now is, what is the influence of heavy lifting on the pelvic floor in our Paris individuals, those who have given birth in the past? And so a new study was just published by Lori Forner and colleagues that was looking at pre-post lifting on pelvic floor morphology in individuals who were lifting 5x5 at 80% of their 1 rep max, and these were Paris individuals. So they had given birth vaginally in the past. what they showed was that there was no difference in prolapse support. So their amount of prolapse pre to post was not different. However, what they did see was that the opening of the vagina was slightly larger before and after lifting, and bladder neck was slightly lower when a pelvic floor contraction was occurring. I had done a previous Substack that was looking at some of these pre to post changes in the pelvic floor in runners and showed something similar where the bladder neck dropped pre to post high intensity exercise. And what we are starting to see is very similar concepts and themes in our lifters. We do not have a comparison group that had never given birth before, right? But it is important to know that these individuals are at higher risk for pelvic floor dysfunction. We have issues around their sport that may predispose them to have higher risk factors for pelvic floor issues. And then we have this change in anatomy that occurs through a woman's obstetrical journey, and then what that does when she continues to be lifting postpartum. I am outlining all of this not to make any sort of negative argument about lifting, right? This is to make sure that we understand from a coaching perspective how we are going to show up for these athletes across their lifespan. Because if I go into my geriatric literature, what we know is that those with sarcopenia, clinically relevant amounts of muscular weakness, have a higher risk for things like prolapse. And frailty, which is a loss of physical resiliency that often shows up as muscular weakness, physical inactivity, and slow gait speed, also is linked to risk for things like urinary incontinence. So there's a protective effect of having muscle mass on our body later on in life. But there's something going on here in this area that coaches need to figure out. And so one of the things that they did in Lori's study, which I think was really fascinating, was they did individual differences, and they looked at each person pre to post, and they kind of mapped it. And what you saw was the majority of people didn't have any difference in pelvic support pre to post lifting. But there were a few that there was a difference or a decrease in their amount of support pre to post lifting. And this is where I want to transition this into the very clinical lens of this. When we are thinking about how we are teaching bracing, that coordinated co-contraction, in strength conditioning circles, we are often saying, what I want you to do is inhale big and bear down into your pelvis or push out into your belt, right? I have done posts about this on Instagram, but what can happen is that a person's bear down in their brace can look the same. When we are bearing down, like when we are giving birth vaginally, we are doing an increase in pressure in our belly on a relaxed pelvic floor in order for baby's head to descend into the birth canal. When we are bracing, our pelvic floor should be contracted as well. And if direction of that pressure is being overdone on the pelvic floor, we are more likely to hit urethral failure. And when we think about our positions in bracing, number one, we need to be thinking about coaching these athletes up. For example, when individuals get into a heavy deadlift, they are more likely to round their back and subsequently put their pelvis into a posterior pelvic tilt. When you do that, you put your pelvic floor in its most lengthened relationship when we think about our length tension relationship, right? So the strongest position for our pelvic floor in our core canister is neutral. It's why so much of our exercise is done in neutral. When we deviate from that, we can take our lumbar erectors, put them on stretch, our pelvic floor muscles and put them on stretch, and then we have this potential increased risk for peeing because our pelvic floor is having a harder time with urethral closure. So that's kind of this one area where we need to be thinking about how we are coaching the movement very globally. And if I am a clinician who is working with these athletes, I need to see them lifting at the load at which they're feeling like they're going to pee, because I need to see if there is a movement mechanic drift that occurs in that moment. The second piece is, are they bracing appropriately? And that's where my internal exam is helpful. I don't even need to do anything internal where my finger is inserted into the vaginal canal. I need to look externally when they are lifting or where they are bracing as if they are going to lift on their back in supine and in standing, to see if they are putting a lot of pressure down into their pelvis. This is my clinical hypothesis. These two things, right? Also, like fatigue and all these other components, right? Is my belief why we had some people who had this difference in support and others that didn't. Like, what I would have been really interested in, and it was not powered appropriately for this, so this is not anything bad to the research team, because it wasn't possible. We would have needed more people, but is to take those people who did have the difference and look at their coordination versus the group that didn't. And that, I think, is what there is a big call in the house for. When I talk about my studies, right, they're observational, they're cross-sectional. I wasn't looking at their pelvic floors because I had, over 600 of them in my first cross-sectional study. There are so many people who are looking for mechanistic data of like what is happening in those people who have leaking versus not. There was a mechanistic study that was looking at muscular strength. Again, this was pre-post. This was not in symptomatic versus asymptomatic lifters, but they didn't see a change in the max contraction of the pelvic floor post-lifting. So it's creating this conversation where we are noticing changes in the pelvic floor after heavy movement, but we would see this throughout the day, right? We also see that there is a drop in our cervix and our bladder neck from the morning to the night, right? So when we're going against gravity with intensity, we are going to show some change over time. And then you sit back and sleep, you kind of reset, and then you are seeing a return to morning levels the next morning. The question is, if you are repetitively lifting on an inappropriate technique, will that potentially have lasting issues down the line? Potentially. Which is why this is a coaching issue. It's a rehab response, right? Where we want to help these women who do become symptomatic, become asymptomatic with lifting. But these numbers of, upwards of 50% of our female athletes who are lifting, having incontinence, that number is just too dang high. Like, that's just telling you there is something going on from a coaching perspective that we have not captured yet, that we are not teaching our female lifters how to lift appropriately for their anatomy. And I hesitate saying only female lifters though, because to not go off on a tangent, this is hemorrhoids, hernias, low back pain, TLJ pain above and below their weightlifting belts for my male athletes as well. And so we have more work to do. But it is very cool that these studies are coming out, that there is just so much more that we know. And I'm just so excited for all the research that we are going to do in the future. Let me know if you have any questions. Hopefully I wasn't too rambly, and we'll see you all next time.